Hello, my name is Kate Chesterman. I'm a salaried GP in South Norfolk, and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify and Apple and Google podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GP Notebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. So let's start this podcast with a case study. Brian is a 67-year-old patient who is known to have bilateral knee osteoarthritis. He comes to see you as he has become increasingly aware of a tightness behind his knee on standing, and on feeling this area, he noticed a swelling. When you examine Brian, you notice a 3 centimetre smooth, fluctuant swelling behind his right knee. Brian has a good range of movement in his knee, and the knee itself does not seem particularly swollen, but you do notice that his right calf is larger than the left. So this is quite a classic presentation of a Baker's cyst, and this is going to be the focus of this podcast. And we're going to think about some of the important factors to consider when assessing and managing this common condition. Baker's cysts were named after the British surgeon William Morant Baker, who first described the condition. Baker's cysts are also known as popliteal cysts, but both are a misnomer, as the swelling that occurs when this condition is not due to a true cyst, but a fluid-filled distension of the gastrocnemius semimembranosus bursa that bulges from between the medial head of the gastrocnemius and the semimembranosus muscle on the medial side of the popliteal fossa. Baker's cysts can occur at any age, but there are 2 age incidence peaks. Firstly, in children aged 4 to 7, and then in adults between the ages of 35 and 70. Primary cysts tend to occur in a young cohort and are thought to arise from naturally occurring bursa filled with synovial fluid. These swellings don't communicate directly with the knee joint, and there is usually no associated knee pathology. They are often symptomless and are likely to be found incidentally when the child or caregiver notices a lump when dressing or washing. Secondary cysts communicate freely with the knee joint and are commonly part of a chronic knee effusion, which herniates between the 2 heads of the gastrocnemius. These are frequently associated with underlying articular disorders, such as osteoarthritis, inflammatory arthritis, degenerative meniscal or cartilage disorders, or trauma to the knee. When the knee is damaged, excess synovial fluid is produced, and this increases the pressure, resulting in the bulge associated with a Baker's cyst. In addition, weakness around the knee and a valvular opening between the knee joint and the bursa contribute to the development. Secondary cysts are much more common than primary cysts. They tend to occur in older people and are more likely to cause symptoms. So, what symptoms are associated with Baker's cysts? Well, they can be completely asymptomatic. Many cysts may not even present with a swelling and might be picked up incidentally on an MRI. Other patients may be aware of a swelling, but frequently have little or no other symptoms. For some, a Baker's cyst can cause pain and discomfort around the knee. Location, duration, and type of pain need to be determined to evaluate whether the symptoms can be attributed to the cyst itself or are secondary to the underlying cause of the cyst. Patients may experience a tightness behind the knee that is worse on standing, as our case study Brian was feeling. Any pain might be aggravated by walking as fluid moves into the swelling from the knee. Occasional locking or clicking in the knee joint can also occur. Large cysts can result in reduced flexion of the affected knee, and some are associated with more pain and stiffness. The size of the cyst and severity of the symptoms can fluctuate. Examination will often reveal a bulge in the medial popliteal fossa that is smooth, fluctuant, and transilluminates with a pen torch. The bulge is frequently tense when the knee is fully extended and softens or even disappears with the knee flexed. This is known as Fuchsia's sign. Large cysts can be associated with calf pain and swelling. Calf swelling is an important consideration. The anatomical site of a Baker's cyst can mean that there is an increased risk of a DVT, and a DVT therefore must be excluded in patients with a Baker's cyst and lower leg swelling. Rupture of a Baker's cyst is one of the most common complications and can result in sudden, intense pain and calf swelling as the fluid spreads into the adjacent proximal gastrocnemius muscle. This can also mimic a DVT and is therefore known as pseudo-thrombophlebitis syndrome. Again, exclusion of a DVT by ultrasound must be carried out with this presentation. Rarely, compartment syndrome can develop secondary to a ruptured Baker's cyst, presenting with sensory or motor deficits secondary to elevated intracompartmental pressures. What other differentials do we need to consider? Well, popliteal artery aneurysms, lipomas, and ganglions can all present with popliteal swellings, as can hematomas, abscesses, and tumours, which could be sarcomas, lymphoma, or metastases. History and examination may be sufficient to make the diagnosis of a Baker's cyst, but if there is doubt about the diagnosis or concern about one or more of these other potential differentials, then further investigation is required. The urgency of these investigations will depend on your level of concern and the differentials being considered. Ultrasound can be helpful to confirm the diagnosis and rule out other serious conditions such as aneurysms or soft tissue tumours. An X-ray can sometimes be helpful in evaluating underlying joint pathology such as osteoarthritis, and MRIs are sometimes used to assess intra-articular disorders such as meniscal tears and can also be helpful in cases of diagnostic uncertainty. If there are concerns about a serious underlying diagnosis, such as a DVT, but also septic arthritis, tumours, compartment syndrome, or joint instability or inability to weight bear following trauma, then an urgent assessment by secondary care should be undertaken. The presence of red flags would increase the risk of these serious alternative diagnoses, and red flags in this instance would include a sudden increase in the size of the swelling or in the amount of pain, a change in the consistency of the swelling, calf swelling, or neurovascular symptoms, as well as a patient who is systemically unwell. So let's go back to Brian, our case study. As mentioned previously, he was noted to have a 3 centimetre fluctuant swelling behind his knee. You shone a pen torch through and noted that the swelling transilluminates. Brian has a good range of motion in his knee, was systemically well, and had no neurovascular compromise. You did note the swelling of his right calf and very sensibly arranged for him to have an urgent assessment for a possible DVT. This was negative, and Brian came back to see you to ask if anything further needed to be done. So, what will you advise Brian regarding the management of a Baker's cyst? Well, given that Brian is relatively asymptomatic, we can initially advise him on self-care options. If he's comfortable, then he may not need any specific treatment. Elevation might help to reduce the swelling, and if he does develop some mild discomfort, then rest, ice, and knee support, and simple analgesia in the form of paracetamol and ibuprofen, if there are no contraindications, may be helpful. A referral for physiotherapy may also be of benefit if symptoms have not settled with these simple measures. If the cyst is ruptured, then the fluid will be gradually reabsorbed into the body within a few weeks, and rest, elevation, and analgesia can ease the symptoms while this occurs. It is important that we consider whether there is any underlying joint pathology and ensure that this is being managed optimally. And this might require a referral to orthopaedics if there is significant damage to the knee joint or to rheumatology if there is any inflammatory arthritis. Specialist input may also be required if the diagnosis is unclear, if the symptoms are troublesome despite conservative measures, or if the cyst is very large. Secondary care involvement can include further investigation with an MRI, or even an ultrasound-guided aspiration with analysis and culture of the fluid. A direct aspiration of a Baker's cyst is not usually recommended in primary care. Other secondary care treatment options can include intra-articular corticosteroid injections, or cyst aspiration and intracystic corticosteroid injections, as well as surgical management of underlying joint pathology, which can sometimes result in resolution of the cyst. Surgical excision of the cyst is not usually indicated, as the risks of complications and rates of recurrence are too high. Reassuringly, most patients with popliteal cysts have an excellent prognosis and rarely have any long-term disability. Most cysts regress over time, but this can take many months, and cysts may reform if underlying knee pathology is not resolved. The management of children with Baker's cysts is similar to that of adults. One of the key differences is that in children presenting with a popliteal swelling, it is recommended that an ultrasound is always undertaken to confirm the diagnosis and rule out other serious pathologies. Baker's cysts in children usually resolve spontaneously without any treatment if there is no underlying disease, but a same-day assessment should be undertaken if there are red flags for serious alternative diagnoses, and a referral to paediatric orthopaedics should be considered for large or symptomatic cysts, to paediatric rheumatology if there are concerns about inflammatory arthritis, such as juvenile rheumatoid arthritis, and to paediatrics or paediatric orthopaedics if the diagnosis is unclear. So thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments, or ideas for future episodes. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.